So we'll introduce Dr. Mosaad Soliman. He will speak to us about tool implication in pelvic congestion syndrome. Success. تفضل يا دكتور موسى.
صباح الخير. واحد من السبجكتس ال very important وهو ال pelvic congestion syndrome و how we can manage, how we can deal with the problem, or how we can improve our success. First described by Richard as a pelvic varicosity. Freund postulated the vascular origin afterwards. Coty believes that it is due to vascular insufficiency due to postpartum thrombophlebitis, and eventually we have the final hypothesis of pelvic insufficiency due to gonadal vein reflux by Taylor in 1994. The pelvic congestion, by definition, is the persistence of non-cyclic chronic pelvic pain for more than 6 months without a known pelvic pathology. And that's why some call it pelvic migraine. It affects 40% of the female population over life and represents 30% of the outpatient visits in the gynecological department, and it represents 15% of the non-saphenous varicosities seen in the clinic. With the differential diagnosis of pelvic congestion, we will go through many things like endometriosis as a gynecological cause, adenomyosis, uterine fibroids, adhesions, and for the urological like urinary tract infection, GI like the irritable bowel syndrome, chronic appendicitis, diverticulitis, and in cases of pelvic floor myalgia like in sacroiliac joint disease, disc disease, and coccydynia. This represents the 4 methods of presentation of pelvic congestion. Could be a valvular varicosities without pelvic congestion symptoms, or isolated hypogastric vein reflux, gonadal vein reflux, or Nutcracker syndrome. And looking at the pathology, it could be a hormonal process like elevation of estrogen and elevation of progesterone as it reaches 10-fold during pregnancy. Also, psychological factors could be an impact, or it could be the result of the problem, or it is a left ovarian vein reflux. So it is a disease of active women, active mentally, active physically by prolonged standing, and active sexually by multiparity, and active sexual life having postcoital ache. So if we look at the anatomy of this process, like in this disease, we will see that 10% of the right gonadal vein is being drained in the right renal vein. We have a left gonadal vein of around 5 millimeters at the normal situation. This vein has some valves in its distal part, and in 15% of the cases we didn't find valves on the left side, and the absence of valves in 6% on the right side. And when the valves are present, they are incompetent in 40% on the left side and in 35% on the right side. Looking at the hypogastric level, we may find that the iliac veins may turn into the inferior vena cava in 10% of the cases instead of the common iliac. They may end in double trunk. They have the parietal and the visceral parts with 5 sites, common sites of communication between the gonadal and the hypogastric veins. These sites are very important because they represent the sites of communication to the lower limb. So you may have an obturator site of communication, sciatic site, superior and inferior gluteal sites, and the bulb, the perineal sites, and finally at the vulvar site. So if we look at the reflux as a pathology, reflux of the renal vein could be result of the thrombosis, tumor invasion of the renal vein, or it could be the result of some portal hypertension and inferior vena cava anomalies. Surprisingly, you may find that in 80% of the case, it is a Nutcracker syndrome. And this is very surprising that you could say, does Nutcracker syndrome represents 80% of the process? Yes, by proof and by clinical assessment. Rarely it is due to a retro-aortic or circum-aortic left renal vein. So if we look at the pathology and how the Nutcracker could result in this syndrome, we will find that normally there is a pressure gradient between the left renal vein and the inferior vena cava. This pressure is around 11 at the renal vein and 9 at the inferior vena cava. When this pressure gradient reaches 5, by 15 at the renal vein and 10 at the IVC, this results in reflux in the left gonadal vein. One more evidence that it is a Nutcracker syndrome in the majority of the cases is the size of the left gonadal veins, which exceeds most of the size around 10 millimeter in the cases of Nutcracker syndrome, and also by the presentation of severe loin pain when you do embolization, because you increase the pressure in the left renal vein, and this would end in a loin pain. One more thing for proof that it is a Nutcracker syndrome is what they call it the left to right shift of the uterovaginal plexus. You will find that there is, in the majority of the cases, there is dilated and refluxing veins from the left side to the right side. That's why in most of the cases, when you do embolization only of the left side, both sides would improve because there is a shift of the blood from the left to the right. You will rarely find when you do selective venography of the right side that a filling of the left side would happen. It never happen. If you do a venography of the right side, you will never see the left side because it is a pressure gradient moving from the left side to the right side. The Shepard has classified the problem of reflux as grade 1 with reflux into the left gonadal vein, grade 2 reflux in the gonadal vein reaching to the uterovaginal level, and the grade 3 shift from the left side to the left side, filling the red gonadals and ending in grade 3. Also, the Shepard has classified the process of Nutcracker syndrome into grade 1, in which on the left side you can see there is an extrinsic impression and visualization or reflux of the gonadal vein or the paralumbar veins. In the middle you will see there is a reflux in the left renal vein and visualization of the gonadals and the paralumbar veins, and on the right side you will see that there is a total cut off of the renal vein. So you can diagnose the problem with ultrasound by visualization of an ovarian vein more than 5 millimeter or dilated veins with reflux with Valsalva. You can see a slow flow at a rate of 3 centimeter per second, or you can see an increased caliber with Valsalva or prominent myometrial veins like this in the ultrasound. With CT, it's virtual, you can see the dilated pelvic veins more than 12 millimeter, but acquisition of the supine position may underestimate the size of the vein. With MRV, it is the best non-invasive mean of diagnosis because there is, you can see, especially when you see the time of flight, because there is intensification of the images from the moving blood and minimal impression by the static flow. You can see the myometrial veins. Venography is a gold standard for diagnosis. You can use it with concomitant intervention or with a non-invasive imaging when it is equivocal, you should see 4 vessels. You should see the 2 gonadals and the 2 iliacs with the tilting of the head up position, experiencing Valsalva maneuver and looking at the reflux. Atypical symptoms goes toward the valval varicosities or dysmenorrhea, dyspareunia, or leuco. I believe we have some time because as the first speaker gave us 2 minutes more.
Your talk is very interesting. So
Thank you.
We'll give you
Full time.
25 seconds.
Thank you. 5 minutes. I can't reach it. So I'll skip some because it is only 1 minute. I'll skip some. You can have an ovarian vein syndrome due to compression of the ovarian by the ovarian vessels to the renals. On examination, you may have a bilateral tenderness at the gonadals and postcoital ache with sensitivity 94%. A presentation in the lower limbs with varicosities, which is non-saphenous varicosities. So if this patient wants to have her life back, or this patient wants to fix her pizza with prolonged standing, you can go to medical treatment, surgical treatment, or endovascular treatment. Medical treatment is useless. I can say it clearly, it's useless. Using medroxyprogesterone acetate, goserelin, ergotamine, venotonics, non-steroidal antidepressants, they are all useless. I can, no, I didn't reach the top. If the next speaker is ready, I'll step down.
There is 2 speakers ready, but we will give you 1 minute more.
Okay, so I'll reach a conclusion. Now we are talking, go for medical treatment, it's useless. We used it for 6 months, it's useless. Surgical treatment with hysterectomy, it represents 15% done for pelvic congestion syndrome, and recurrence rate is high. It is high as well for surgical and laparoscopic ligation of the ovarian vein with endovascular intervention by coiling. This is a very important algorithm, but we are lacking time. Like a Nutcracker syndrome, surgical decompression of the renal vein from the IVC with a retro-aortic renal vein. We would do this by isolation of the aorta and the inferior vena cava, clamping of the renal vein, transposition of the renal vein in front of the aorta, and finally interposition. Endovascular treatment either by coiling or sclerotherapy. We will do sclerotherapy with hypertonic saline solution. And what I need to conclude, it is underestimated problem, represents a major impact in the female life. This problem is easily to be corrected if you diagnose it. Combination of embolization and sclerotherapy is very important because coiling only would leave a leak underneath, especially if you use a coil less than 20 millimeter. So if you find that there is still a leak, you should induce sclerotherapy. Thank you very much.